crises, fragile settings already tethering on the edge will be the hardest hit. They are the first to lose access to essential commodities, to life-saving care, and to the basic public health services, which are often taken for granted. Colleagues, the numbers are stark. In 2025, the least developed countries are projected to see a devastating 13 to 25% fall in net bilateral ODA. Countries in sub-Saharan Africa could face a decline of 16 to 28%. These are not abstract statistics, which I'm sure you will all agree. These represent lives of individuals. These represent a significant blow to the ability of nations to build resilient health systems and protect their own people. In parallel, we are also seeing that domestic spending on health is declining, and in many low and middle income settings, it is out of pocket expenses paid directly by individuals and families that continue to be the primary source of funding. So, what do we do in this regard? But just to break it down a little bit before I move forward, in the face of these cuts, we know that women, children, and adolescents have the most to lose. They stand amongst the most vulnerable of populations. If we want to understand a true cost of funding cuts, we need to just look at a bit backwards. A review of aid sanctions from 1990 to 2019 found that they were associated with a yearly increase in maternal mortality of 6%, an increase in child mortality by 4%. And the projections for the future are even more stark. Evidence points to a devastating reality that an estimated 14 million additional preventable deaths worldwide by 2030. More than 4.5 million of these deaths will be that of children under 5. Looking further ahead, for the period 25 to 2040, the long-term impacts of reductions to foreign assistance on women, children health are even more dire. When we compare to 2024 baseline, these projections suggest that maternal mortality ratio will increase by 25% at least. The mortality rate for children under 5 would increase by 23% and stillbirths by 13%. These percentages translate into a tidal wave of human loss. We are looking at an additional 510,000 maternal deaths and another 500,000 deaths due to the loss of family planning services. We are looking at an additional 7.9 million children dying and 1.8 million stillbirths. We have done a brief mapping, and in the interest of time, I'm not going to go through great details on this particular slide because we do want to hear from the Ministries of Health and experts on the call. But I just wanted to say, for the Global Leader Network has undertaken a rapid mapping exercise of various initiatives supporting the domestic resource mobilization effort, identifying at least 12 at the regional level and 7 at the global level, which are enlisted in front of you. These range from mechanisms like the Global Financing Facility, which helps prioritize SRMNCH plus N interventions, provides grants and allow countries to leverage IDA funds to join learning platforms and initiatives. And through these initiatives, countries are making a concerted effort to increase strategically allocated domestic resources for health and moving away from a reliance on external aid. And this is where we come to a special segment in this webinar series that is being launched today. Today's webinar marks the start of the series of webinars aiming to address the critical issue of declining aid for global health by focusing on domestic resource mobilization. We have planned 6 webinars in this regard, and the series will explore successful country-led strategies and innovative financing models that have improved health outcomes, particularly for women, children, and adolescents. It is an opportunity to promote specific policy actions to enhance domestic spending on health and protect funding for these vulnerable populations using real-world examples and demonstrating how high-level political commitments can be transformed into implementation around the world. Thank you very much for listening. I very much hope Honorable Minister is able to join us today. So I will stop speaking now and hand it back to you.
Thank you very much, Dr. Rajat. And I am pleased to report that our host, the Honourable Minister of Health of South Africa, Dr. Motsoaledi, is now able to join us. So I'll invite welcome remarks from the Honourable Minister. And while he's getting his screen on, I'd like to acknowledge the presence of our other keynote speakers, the Minister of Health for Ethiopia, Dr. Megdez Daba, the representative of the Minister of Finance for Malawi, Dr. His name again. The Minister for Mr. Kandio, who is representing the Minister of Finance for Malawi, and also recognize the presence of the Director General of Africa CDC, Dr. Kaseya. As I said, I won't spend too much time introducing our guests and keynote speakers to make sure we use the time most efficiently. So, and to remind you, this is being live streamed, and so recordings will also be available afterwards. Honourable Minister, please welcome and go ahead.
Thank you very much, my sister. Can you allow me to not to appear on the screen? I can't look at the screen for a long time. I've just had an eye operation. Can I just address you without you seeing me on the screen?
Otherwise, your voice is as good as your face for us, Honourable Minister, so please go ahead.
Thank you. Thank you very much. Program Director, Dr. Ebere Okoreke, Your Excellency, Minister Megdez Daba, Minister of Health of Ethiopia, Your Excellency, Minister Simplex Chidiola, Minister of Finance of Malawi, Your Excellency, Dr. June Kasia, Director General of the African CDC, Mr. Rajat Khosla, Executive Director of the Partnership for Maternal, Newborn, and Child Health, distinguished speakers, webinar participants, and members of the media. It gives me great pleasure in our capacity as the chair of the Global Leaders Network for Women's, Children, and Adolescent Health to launch the Domestic Mobilization in Action webinar series. This webinar series is an official initiative of the Global Leaders Network in partnership with National School of Governance. I wish to acknowledge the visionary leadership of the heads of state and government of the Global Leaders Network and for their steadfast support of the PMNCH. This initiative is the brainchild of the Global Leaders Network membership itself. Recognizing the challenging global health financing environment, the membership resolved to create a platform that is not simply convening, but rather a strategic intervention to safeguard the health and dignity of our people. We are facing a global financing crisis of unprecedented scale. On the 4th of July, 2025, Loeb et al. Project that in 2025, overseas development assistance will fall by a total of 31.1 billion US dollars. They further postulate that ODA from high-income countries is expected to decline due to a combination of budget cuts, reduced indoor refugee costs, and reduced GDP growth, and that the small expected ODA increase in three markets, namely Japan, South Korea, and Italy, will not be able to cover the losses. The consequences are stark. This year, McKinsey told us that funding for maternal health may drop by 23%, child health by 17%, and family planning by 34%. These cuts threaten to unravel decades of progress and disproportionately harm women, children, and adolescents, those who are least responsible for fiscal shortfalls, yet most vulnerable to their consequences. The impact of this crisis continues to reverberate across health systems on the ground. As governments, the sage advice of Dr. Ngozi Ojuela-Luela, Director General of the World Trade Organization, come to mind, and I quote, "Africa, we really need to change our mindset. Access to aid can begin to think of as a thing of the past. We have to focus on two things: attracting investment and mobilizing our own domestic resources, close quotes. As African countries, we have done our best to mobilize domestic resources and leverage strategic partnership to stimulate even further domestic mobilization. I am grateful to the South African National Treasury for assisting us to mobilize just over 750 million South African rands from our already contracted coffers to address the withdrawals in our own country. We also entered into a match financing agreement with Gates Foundation and the Wellcome Trust to close to 600 million rand together with our treasury to fill up the gap on research. We take pride in other examples like Nigeria, a GLN member state, where the coordinating Minister of Health, His Excellency Mohamed Patel, facilitated the domestic mobilization of 200 million US dollars following the US withdrawals of ODA to health. Just over a week ago, President Bogo declared a public health emergency as it faces a critical shortage of essential health products. He announced that his treasury approved 18.5 million US dollars in emergency funding to address the supply chain issues. In his address, he highlighted that managing the shortages will be highly price sensitive due to our limited coffers. We are not short of examples of countries squeezing out emergency funding despite facing fiscal constraints, which signals an encouraging level of political will and determination to exercise our own agency. However, Africa is not alone in this crisis. There are many other low and middle income countries in the global south that are grappling and competing with competing priorities and attempting to implement accelerator programs in a complicated environment where the resources simply do not follow to the areas we wish to prioritize. The situation demands that we must respond with bold, coordinated action. Increasing national health budgets and protecting allocations for women's, children's, and adolescent health is not just optional. It is part and parcel of our global development agenda. Diversified financing mechanisms such as blended finance, health taxes, and the results-based funding must be scaled, not sidelined. As an example, the G20 Joint Finance and Health Task Force Secretariat recently told us that health only accounts for less than 10% of blended financing transactions globally, suggesting that as a sector, we are far behind other sectors in adopting and developing sustainable, diversified financing models. But innovation alone is insufficient without sustained political will, policy coherence, and cross-sectoral accountability. South Africa stands ready to partner with all of you to advance the cutting-edge policies, including the Lusaka Agenda, the World Health Assembly Resolution on strengthening health financing globally, 2025, and the recommendations of G20 Joint Finance and Health Task Force. We recognize that fragmented, siloed initiatives dilute impact. Our commitment is to harmonize efforts, elevate women, children, adolescents within national health priorities, and ensure that domestic resources mobilization becomes a cornerstone of resilient health systems. This webinar series is a strategic platform to catalyze change. It will spotlight country-led innovations, alleviate policy levers, elevate policy levers rather, and foster cross-country learning. Most importantly, it will position political leadership and not just technical expertise as the driving force behind sustainable health financing. This global leaders network's mapping and description of 19 initiatives thought the GLN mapping exercise, which was conducted this year, reveals both opportunity and fragmentation. This series aims to convert that fragmentation into focused collective action. Mr. Rajat Khosla has already discussed this further as he presented. We must emerge from this series with more than insights. We must feel confident to onboard new, diversified, and innovative strategies as we learn from each other's successes and opportunities. We aim to affirm the political will of Global Leaders Network member states, draw in countries from the Global South, and resolve duplications and fragmentation in the global health financing architect. Let this series be the turning point where domestic resource mobilization becomes not just a policy goal, but a political priority. Colleagues, the time for cautious optimism has passed. I'm just finishing.
Sure.
We must act with urgency, clarity, and conviction. I call all the nations, stakeholders represented here, to engage fully in this series, share their successes and failures, and commit to protecting the health of those most at risk. Together, we can transform this moment of fiscal constraints into a movement for health justice and sustainable investments. I thank you very much. I'm sorry, my sister.
Thank you very much, Honourable Minister. Not at all. We're really grateful that you were here to host and welcome everybody to join us today. And I want to pick on 3 points that the Minister referred to here. He talked about political will, policy coherence, and cross-sectoral collaboration. And so, just again to remind you all, this is being live streamed. I think we have almost 180 people online at the moment. Thank you very much, Honourable Minister, for setting the scene, and thank you again to Dr. Khosla for the lead up to why we're here. So without much ado, I'd like to move straight in to get our keynote VIPs to reflect on this. I'm building from the Honourable Minister's statement about cross-sectoral collaboration. I'd like to move to our representative of Dr. Banda, the Minister of Finance and Economic Affairs for Malawi. We have Mr. Grecium Kandio, who is Director of Revenue Policy for Malawi, representing him. And Mr. Kandio, I want to start by saying we keep talking about domestic resource mobilization, and that is first and foremost not just a cross-government responsibility, but is rightfully led by the finance sector. So I would like to hear from you what practical steps you are taking in Malawi to increase access to revenue to support the health sector, and particularly the needs of for groups that were most vulnerable, women, children, and adolescents. So over to you, Mr. Kandio, if you could unmute yourself to get your camera on, please. Thank you.
Thank you so much, Dr. Ebery. I would like to salute the Honorable Minister of Health for the Republic of South Africa, Dr. Mosoaledi. Again, my salutations to Dr. Magdas Dawa, the Minister of Health from Ethiopia. And I would like also to send my salutations to Dr. Rajat Khosla, the Executive Director for Partnership for Maternal, Neonatal, and Child Health, that have joined this particular webinar. Indeed, this webinar and the initiative presents a critical chance for our countries to reflect on the matters of national importance pertaining to the health sector in view of the rapid withdrawal of donor financing that has put pressure on countries, including Malawi's health financing. With regard to the political actions and the commitments that have been made by Malawi to increase domestic revenue mobilization in our current setting, there has been of late a demonstrated strong leadership and political backing in the DRM domestic revenue mobilization agenda, championed by the Minister of Finance, by providing revenue policy guidance and championing key public financing reforms. Under the Malawi domestic revenue mobilization strategy that was implemented in the year 2021, which is running up to next year, the year 2026, and the National Health Financing Strategy for Malawi, which is running from the year 2020 to the year 2030. Malawi is geared to broaden the tax base and to strengthen tax compliance, to increase domestic revenues to finance critical government financing obligations, including the health sector, and also introducing the health taxes through a reform to our tax legislation to generate additional revenues to prioritize or to channel them towards the health sector. We are also promoting public-private partnerships to achieve efficiency and mobilize additional financing for the health sector, including collaboration with the Ministry of Health by implementing public budget cycle activities necessary to achieve universal health coverage goals. These reforms are backed by strong political leadership, with the Minister of Finance and the Minister of Health working closely together to prioritize health investments that advance Malawi's 2063 agenda, which is geared to put Malawi as a middle-income economy within the global context. We are also working with the Ministry of Health to ensure that resources mobilized in the DRM strategy directed towards primary health care, where women, children, and adolescents also receive particular attention in the delivery of government services. I submit at this particular point. Thank you.
Thank you. Thank you very much, Mr. Kanjo. That was very clear, run through the priorities as to how we actually expand the tax base and by much more accountability and ensuring that we actually get there's better tax compliance, as well as looking at innovative taxation through health taxes, the so-called sin taxes. We welcome the mention of the engagement of the private sector as part of the solution. We acknowledge that this is not a government problem, a problem for the government to solve alone. And we welcome very clearly how you've outlined the need to collaborate between the Ministry of Finance and the Ministry of Health. Thank you very much. And that is a perfect position for me to bring in our next VIP speaker. And I'd like to welcome Dr. Megdes Daba, who is the Minister of Health for Ethiopia. Her Excellency, Ethiopia has accelerated the move towards expanding the domestic resource base for health. And I would like you to maybe reflect towards how traditionally finance ministers tend to look at health as purely an expenditure ministry. And how we hear interesting reports about compacts that the Ethiopian government are leveraging between the Finance Ministry and Ministry of Health to expand investment in the health sector. Could you tell us a little bit of how you've lobbied for greater prioritization for health in the national budget, and especially how those resources are targeting women, children, and adolescents? Over to you, Dr. Megdes.
Thank you. Thank you very much, Dr. Ibrahim. It's always a pleasure to be with you and Excellency Minister Dr. Matsoaled, Minister of Health of South Africa, Your Excellency, the Minister of Policy, Director of the Policy and the Minister of Finance, Mr. Kadus of Malawi. It's a pleasure to also join significant panelists like Dr. John Kasai, our Director General of African CDC, Your Excellency, and Dr. Braja, the Executive Director of PMNCH, all Excellencies, distinguished participants of our panel. It's really an honor for Ethiopia to be a participant in the launch of this domestic resource mobilization and webinar. This is a webinar that is very keen and which Ethiopia is very keen to participate at. A webinar that is as a proud member of the Global Leaders Network for Women, Children and Adolescents Health, Ethiopia commends the chair of the Global Leaders Network, His Excellency President Ramaphosa of South Africa, for championing health for women, children and adolescents. Our collective political action of South to South knowledge exchange, which have facilitated an acceleration of reduction of women, child and adolescent mortality over the years have been significant. This webinar series, and I would say, is very timely. It really represents the immediate response to health financing challenge, which has been exacerbated by a reduction of the ODS shift that our continent and also the globe is seeing nowadays. As deliberated in the 75th session of the WHO Regional Committee for Africa, this webinar launch directly responds to two core action items that were presented by the Ministers of Health and delegates that had endorsed two agendas. One is around facilitation of South to South learning and regional collaboration, ensuring that joint accountability for our women, children, adolescents' health is taken into an agenda. And another one is undertaking a regular high-level policy dialogues like this one on health financing, where we can ensure that universal healthcare coverage positions women, children, adolescents' health as a top priority on national strategic agendas. And Ethiopia fully supports this webinar series. And what we're doing so far is taking that leadership as the chair of the national and sub-national level. At a national level, we come together on a joint steering committee, which meets regularly to facilitate the implementation of Ethiopia's policies. In those meetings, I champion the increased allocation of resource to primary health care because domestic resource mobilization needs an alignment at national level initially, with a platform of delivering with high impact interventions that will target women, children and adolescents, and the programs can be different. It can be nutrition, it can be the other additional needs of our women and children and adolescents. So leadership is very important. And the other thing that our country needs is progressive policy change. With domestic resource mobilization, there are going to be a need, and what Ethiopia is doing parallelly is several change in progressive policy shifts. We have recently changed our national health policy, which has been in place for 30 years, because what worked over the past 30 years is not the same. We have seen the change from COVID and what countries need after the change that we are already seeing with the ODA shift. There is a several change on domestic progressive policy change. We have national policy with the health sector transformation and investment plan. It's not just the transformation, but the investment linked to it. We take a policy to provide guidance to our partners, investors, donors who want to come and partner with the country with a Lusaka agenda where healthcare financing through health insurance and ensuring primary health care is at the center of it. Through this reform, what Ethiopia has done is it covers a minimum of 45% of its population. It is nearly almost 50% with the population we have now, with community-based health insurance system, which covers 63 million of our population recently. And within the next year, we will be implementing also a total social health insurance coverage with a pool resource of community-based health insurance system, governed and also led by the government. And this is also to ensure that our communities, especially people in need, are not left behind. So anything we talk about health financing cannot be undertaken unless we take the health financing and health insurance at the middle of it. And we have already mobilized 63 million in coverage for this. The other one we do is also healthcare reform. And as we speak, we're also doing a recent and also a robust healthcare reform as part of a civil service reform, but also private sector engagement with public-private partnership, implementing policies for visibility. One thing is the one plan, one budget, one report mechanism that our continent with the 2063 agenda, which through the different mechanisms, including African CDC's chairing and other relevant sectors supporting us in the Lusaka agenda, because it's a country-led initiative. Integration and reduction of redundancy, audit mechanisms, introduction of new taxing mechanisms. But Ethiopia has done a lot in the health taxing, including sin tax previously, but attaching it with the health financing is where we are now trying to improve more. So there is a lot to do, including digitalization and efficiency of tool, because whatever we do cannot go further unless we have visibility. So we have now linked maternal child health and adolescent investment to visibility. And recently, we have more successfully lobbied and also gathered other like-minded partners together for a model of funding where the government, donors, and communities are coming together. It is about compacts. We have a lesson from Family Planning Compact when the initial funding for family planning was reducing over different years. And then now we expand to the maternal child health and adolescent health, entire package of MNCH compact, where the government would match funding that comes for maternal, newborn, and child health commodities. And we're also engaging different ministries. This, I'm really happy to see Ministry of Finance even participating in here. Other relevant sectors like Ministry of Education, Ministry of Plan are coming together, and we present our case to the Parliament, to the Treasury every time. So this time, for the funding cycle reprioritization, we made sure that women, children, and adolescents is a national priority. It has been a priority, but we made it, and again, another big priority to use data-driven change with exempted services, engagement of community. So I would just be saying three things. We can do different things from innovative financing. The country has also brought up new bill mechanisms for health workforce compact, because these sectors that we talk about, child, maternal, and newborn care, are usually at a primary level. So we need the health workforce in a larger number around there. So we are also doing a health workforce, HRH compact, but the Ethiopian government has also recently allocated a different modality of financing with Ethiopian Disaster Risk Response Fund, which is recently passed by the government ratified bill. And we're now implementing innovative additional financing models to mobilize domestic resources. So I would say we need to still stick to supporting the Lusaka agenda, partner with others, and support country-led domestic resource mobilization, bring the strategies together, align them, reduce redundancy, support resource pooling, allocation, not only at a country level, but as a big national regional agenda. Take the opportunity as a challenge, and I'm sure we need to believe in each other, because this can be an opportunity for change. Thank you.
Thank you very much. Thank you very much, Dr. Megdes. And I like that call that this is an opportunity for change that we should all grasp. In the initiatives and the innovations and changes that you described that Ethiopia is taking, I picked up the synergy with some quotes that comments that Dr. Donald Kaberuka, former chair of the African Development Bank, made just a few days ago in Nigeria during their health financing dialogue. He talked about the 4 A's: availability, accessibility, affordability, and accountability. And in your summary here, you've touched on each one of those, how we actually make sure that we use the money more efficiently, how we're accountable for the resources we have, we make them more available, and affordability, health insurance being a key approach to that there, which is really welcome. I would just segue just briefly to mention that those of you on social media might have picked up, there was a very tragic story on social media about a woman who was pregnant, and due to inability to provide the cost to access care, she was walking around with stillborn children and unable to actually receive attention even after the children had died. And that was a really tragic reflection about accessibility and affordability and the need to make health insurance available to the most needy. So I just wanted to remind us that there are human beings and individuals behind these policies and resource mobilization priorities that we're defining here. And it feels like a really perfect situation to take us on to our foremost public health technical institution on the continent. Your Excellency, Dr. Kasey, as the Director General of Africa CDC, I know that as you have taken on your remit, I have your book, the Green Book, where you've laid out your priorities as you understand them to support governments to respond to this new financial era. And so I'd like to ask you to reflect on if you could take from the many recommendations you've made, pick one initiative that you think governments across the continent should prioritize to address this financing crisis, particularly recognizing the vulnerability of women, children, and adolescents. Over to you, Your Excellency.
Thank you so much, my sister, Dr. Ebere. We are not meeting. Huh? I think we need to find the time to meet again. Huh? And let me also recognize my brothers, especially the Minister of South Africa, Minister Motsoaledi, my sister Megdes, and also Dr. Raja and the representative from Ministry of Finance, Malawi. Yes, I will start by thanking our champion, President Ramaphosa. He is championing this agenda and is initiating this Global Leaders Network webinar series for us to reflect. You know, we can't stop thinking about what is going on in Africa. And when I had the opportunity to discuss with President Ramaphosa in Japan, he clearly told me we need a clear vision, we need champions, we need tools, and we need resources. I think when you are talking with someone like President Ramaphosa, you take note of what he's saying. Coming clearly to your question before going there, I'm taking this call from DRC because, as you know, yesterday the government announced this Ebola outbreak. But what is sad, because we are talking about women, adolescents, and children, what is sad is the index case was a young person, 34-year-old woman, who was pregnant 34 weeks. And he came to the hospital, she passed on because first, we didn't detect on time, and second, she didn't get access to medicines that could save her life and the life of the baby. This is what is making critical when we are talking about the outbreak response, the PPPR agenda. We cannot disconnect that with health financing. Now you will understand why our leaders in Africa, they gave to Africa CDC the leadership to lead this agenda of health financing. Africa CDC didn't impose himself to lead that. It's African head of state who said, we want our public health agency to lead this agenda, to bring head of state, to bring ministers together, to give us the vision, the way to move forward. Currently, as my colleagues, they shared, this ODA issue, it's sudden, that is making the situation worse. But if Africa was informed and was given time, I think the decrease of ODA could be seen as a major blessing because Africa will be well prepared. What are we doing? We started by analyzing the situation at country and continental level, the Green Book you are sharing. Mostly we are talking about three major barriers. The first one, the fragmented health financing. You have so many programs, vertical programs, even donor-driven mechanisms that are not supporting the national budget ownership. This is the first one. The second one, we have a weak public financial management system in place. Inconsistent budget execution, inconsistent budget allocation, poor absorption capacity, limited fiscal space, all of that are impacting the health system. But we have also another factor, mostly when some countries are going through election, like now in Malawi, we have election. You will see that in most of the countries, health start not to be a key priority because the priority is election. Sometimes the priority is security, like in DRC and other countries. What are we doing? We are making sure to reposition health as a key priority. We are changing the narrative. We are bringing the health financing as a political agenda. Minister Motsoaledi, Minister Mekdes, and my colleague from Malawi, they shared a lot of experience from South Africa, from Nigeria, from other countries. But let me share with you what we are doing also. We are supporting DRC. You know, this is a country, with our support, they decided to implement what we call a tax bringing 2% of all goods imported in DRC for the health sector. In addition to that, they are applying 2.5% to all salaries from private and public sector. Overall, that is generating around $1.4 billion per year to this country. Now we need to support this country on the best way to plan and to use this money that is additional to the national health budget. This is something concrete. Many countries in Africa are going through that, supported by a number of partners. What we are doing as Africa CDC is to make sure that we bring all of these experiences together. This is why you saw us advertising 10 positions of the public finance management specialist to be based in 10 priority countries, because we want to help means of finance, means of health, means of planning, means of budget to speak with one voice. We want health sector to speak the language of finance sector. This is what we don't have regularly. These 10 people, they will help to not only support to mobilize more domestic resources, but also to make sure that the Lusaka agenda is implemented. I have to say several days. And I want also our colleagues who are working with us in the past, now they are working with donors to continue to say that we need to implement the Lusaka agenda. Lusaka agenda is not an option. Lusaka agenda must be implemented in Africa. We don't want to see again a partner coming and saying, I have my own program, I will implement that without the government leading and knowing. Mostly, people who are working with our donors are also our own people in Africa. Help us to tell your colleagues the Lusaka agenda is not an option. We are also talking about how to use other opportunities, the blended finance. We need to invest in Africa. Minister Motsoaledi and myself, we are discussing several times about local manufacturing agenda. But local manufacturing agenda is not a public agenda. It's also a private sector agenda. Our people who are coming to invest can have return on investment. And it can be possible only if people like in South Africa, they don't just think about the South African market. We need to think about the African market, the 1.4 billion people that we have. This is why Africa CDC submitted to head of state, and we got what we call the African Pool Procurement Mechanism. Many partners, when they don't want to support the local manufacturing agenda, they are talking about market. We have a market. These 1.4 billion people are human beings. They are using health commodities. This is the market we are talking about. This is why supporting the African Pool Procurement Mechanism is creating added value. It's transforming health sector from liability to an asset. As I have to say, 35% of all products exported by Switzerland are pharma products. We know the contribution of the pharma sector in India. Why Africa cannot use that as an opportunity? As Director General, I say every day, I will not accept to be threatened. Africa will not accept to be threatened if we see some colleagues coming to tell us, you cannot manufacture a vaccine, you cannot manufacture X product. We'll do that. We'll do that for our health security. We'll do that for our economic growth. We'll do that for our job creation. We'll do that to take opportunity to leverage on the innovative thinking of our young people. This is why this green book that you are sharing is the most comprehensive document that Africa developed for health sustainability and sovereignty. And I'm thanking President Kagame, supported by other leaders like President Mahama in Ghana and other presidents, we are giving names here, for championing this agenda. And I think we'll have opportunity to continue to interact because this series of webinar will help us with other opportunities that we have to make sure when we'll sit in February 2026, when Africa CC will submit the scorecard to the AU Assembly, we can say to our leaders and our communities, we moved from A to B, and we are moving from B to Z in a few years. Thank you so much.
Thank you so much, Your Excellency, Dr. Kaseya. And I wanted to just pick on, there were some really concrete examples you gave us, which is a perfect transition to our next session. I love the example of the actual practical intervention around levies from salaries that you in DRC. We welcome your innovation around capacity building by providing these public health financing experts. We recognize that health ministries, health institutions tend to really struggle in actually understanding and articulating the language of finance and investment and impact investment. So this expertise is most welcome. I also acknowledge your push that we actually see the health sector as part of the economic growth of the continent and the opportunities through localized manufacturing and pool procurement to actually leverage the population on the continent to bring us away from this culture of dependence. Brings me again to, I will quote Dr. Kabaruka again because he's my favorite public finance person. He always says there is no sovereignty without financial autonomy. And this links into the conversation that we had at the Accra Summit about health sovereignty, the importance of actually aligning that independence of policy in health with the funding, making sure that the resources align with our ambition and our policy. So really welcome and thank you, Dr. Kaseya, for this inject that brings us to a nice connection to the next section. So it's on me to thank our VVIPs on this first section. Again, starting by our host, the Honorable Minister of Health for South Africa, for the call to action, the charge that we move from rhetoric into action. I'd like to thank Dr. Megdes from Ethiopia, Minister of Health for Ethiopia, giving us concrete examples of what's happening in Ethiopia. I'd like to thank Mr. Gresium Kandio for articulating how the finance ministry in Malawi is prioritizing health in terms of its policy, its revenue changes. And finally, to Dr. Kaseya for reminding us about how important, how central health has to be to our search for autonomy across the continent. So with that, we bring this first and foremost, again, finally, I would like to thank Dr. Kostler for the scene setting, a brilliant, succinct setting of why we need to actually have these webinars so we can actually be singing from the same hymn sheet and understand what works and what doesn't and accelerate our progress in this space. We're now going to move into the second part of this section. I'd like to remind our past participants online, please use the Q&A button if you have any questions. This is a section where we will now be picking those up. I'd like to remind our next set of speakers to get ready and to once more mention there is interpretation for those of you who joined late. Click on the globe button and pick the language you prefer if you have interpretation just from English to French. We have, again, still almost 180 participants online. This is welcome. It's also being live streamed from YouTube and therefore will be available to view later on. Now, without much ado, we'll just get our next set of speakers teed up. Please stay online. And we will start looking at concrete examples of what changes have been implemented in response to this. This is no longer just a crisis. The health financing, the change in the health financing architecture is the future. So the changes that we're talking about and implementing now are not just a transitional thing. They are the way we have to go forward. So I'd like to start by welcoming our first speaker in this section, I would like to invite Dr. Ogochukwu Chukwujekwu, who is the team lead for health financing and governance at the WHO. And he will be talking to us about how national health accounts can be used for countries to track health spending and therefore monitor progress to domestic resource mobilization and support evidence-based budgeting and policy decisions. So Dr. Ogochukwu, welcome. I don't know do you have any slides or do you just want to speak?
I have a few slides.
Okay, so please go ahead and project them. And I'd like to remind our participants, we will take questions after our 4 next speakers have concluded. Then we will take all the questions together. So please get ready with your questions. We will collate them as we go along. Over to you, Dr. Ogochukwu.
Okay, thank you. Just 1 minute. Great. So thank you so much, Dr. Ibere. I will not be making a presentation as such, but just use some of the slides to speak to the issues around expenditure tracking and how it supports our work in health financing overall. As our keynote speakers already mentioned, we understand what the ODA cuts have, they're having really strong impacts in countries in our region. And I think some of the information that we will be seeing now also help to demonstrate why this is the case and why countries in Africa are particularly vulnerable to this. The health accounts is one of the, I would say, a comprehensive way of looking at how health spending flows. And as I listened to all of our keynote speakers, one of the things that kept popping into my mind is really how do you monitor all of these great initiatives that are being done? How much money is being raised? How is it being spent? Who is benefiting from it? And these are some of the questions that countries try to understand, and the framework for health accounts to try to demonstrate. And the slide I am showing here it's not to make all of us health accounts experts, but it's really just to show some of the different dimensions and aspects that can be monitored or measured in the course of estimating health expenditure for countries, starting from the sources of financing to the agents, and that means who funding flows through. And then to which providers are receiving this, to which types of health services. And countries can even go further to understand what types of disease conditions or health conditions are benefiting more from health spending by age grouping, by subnational level for countries that are decentralized. Now, taking off from where Dr. Rajat shared earlier, if we look at the African region, very simply to highlight some of the different sources of financing, we've talked a lot about domestic resource mobilization. This is the theme of this webinar series, but we can actually see that in Africa, the domestic spending is pretty not the most dominant form of health spending. And although it has grown a bit in the past decade by about 4%, it still represents just over a third of spending. And by far, financing is driven through out-of-pocket spending in the region. And this is one of the reasons why our populations continue to face a burden. But I do want to point to the fact that, of course, when we look at external spending, and this is why the ODA cuts are so intense for the region, that we are seeing this average of about 24%. That's a full quarter of spending in the region coming from external sources. And these are the sorts of information that we do get from the routine monitoring of expenditure through the NHA. And when we look at by country as well, we can see the exposure of our countries in many ways, with up to 6 countries that are having nearly half, 45% or more, of all spending in their countries coming from external sources. And with ODA cuts, we can see how these will be affecting not just simple programs, not single programs or singular or sub-programs, but has the capacity to really push the entire health system off kilter. Now, onto the, the bigger theme of reproductive, maternal, and child health in the region. One, I started by, speaking about the need to monitor all of the great initiatives that countries are putting in place. And we find that when it comes to the more detailed breakdown, who is benefiting from spending, in fact, that becomes a bit more of a challenge. That while we see countries are reporting data at a top level, but getting some of the breakdown to really understand who benefits, it becomes more problematic. When we look at RMNCH, there are only about 11 countries that provide information consistently. Year on year, you may get a range of countries ranging from about 15 to 30 from one year to the next, but actually only 11 have consistently provided data on reproductive, maternal, and neonatal health spending, and only 10 have consistently provided data on child health. But even from those numbers, we can see that while child health appears to have a fairly, maybe a quarter of spending on health, even though the absolute amounts are still not what we would expect to be able to provide an appropriate package of services for children when it comes to reproductive health and maternal neonatal health. Actually, those numbers are much lower. And those are the questions. I think these are the things that would help us to reflect on why spending on these groups or on these sets of conditions are lower than we would expect, and what services are being really fully supported within this. And when we also look at the financing at a regional level, this is for the same numbers. We do find that government spending at earlier years was actually higher, but was beginning to fall over the years, while this is being replaced a little bit more by external financing. But with the ODA cuts, then we find that RMNCH becomes a program that is very heavily hit, and so the health of women, children, and adolescents' health is really challenging.
Dr. Ogo, I'm going to ask you to bring it to a conclusion, please.
Mm-hmm. Okay, great. Mm-hmm. So I will actually just stop quickly, round up quickly by talking about how with the information that I've presented, the process of tracking health expenditures and routinely reporting them back to both to the public and to policymakers is something that helps governments to keep themselves accountable, monitor the commitments that they are doing. It can help to guide resource allocation and to understand where we're underspending. And I think we've demonstrated that a bit by looking at how spending on women, children, and adolescent health services is less than we would at least hope to see. But it also provides information that can help ministries of health make really strong cases to the ministries of finance on the need to increase allocations, showing this spending per capita or the programs that are underfunded and need to keep going up to be able to meet the country's health priorities. I will bring this together that it, by saying lastly, it does provide the information that is needed for broader accountability and advocacy by all stakeholders. So not just for governments, for civil society, for parliamentarians, for partners to monitor how we work together to finance health. Over and back to you.
Thank you very much, Dr. Ogo. And just to remind speakers, in order to ensure that we have time to take questions from the audience later on, please let's be succinct and also let us be solution focused. So, Dr. Ogo, you mentioned that the data is useful, it's helpful, but you also highlighted that very little of it is actually collected at the moment and used for the purpose. So I would like to ask you to respond in a single sentence, 30 seconds maybe. So how do we make sure that this data is available so we can actually use it? Because it's no good telling people we're putting more money into health if we can't track it. Briefly, please.
Now, well, one sentence is a tall order, but I will try. I'll say it really is about the different sources of data. And so if I start from one of the most important sources, government spending is something that we've got to track. Having the transparency to share all of the information that is being monitored through budget execution and through the different financial management information systems is key to ensuring that the right level of detail and the right information goes into the analysis for the expenditure tracking. That's one. And then the second important one is with external funding, a big challenge is always getting donors, partners to fully share what they're doing, how they're passing money through, and having that agreement and accountability between parties with the government leadership will be critical. Over.
Thank you very much. Thank you, Dr. Ogo. And again, to remind all our next speakers, please keep to time so that we have time to take some questions. I'd like to invite, following on this same vein about tools and programs for actually monitoring what we do and doing it better, how we do monitor the use generation of more domestic resources for health. I'd like to welcome Dr. Tina Chisenga, who is the Acting Director of Programs for East and Southern Africa Health Community. And she will give us you're not using slides if I recall correctly. Yes, so you're going to talk us through a reflection on the tools that are available to support this agenda. So over to you, Dr. Tina. Welcome.
Yeah, thank you so much, Dr. Ebere. And I'm really honored to be part of this first session on domestic resource mobilization webinar series. On behalf of EXA, I would really want to share some of the tools that we have at hand. First and foremost, I want to make mention that we're an intergovernmental organization, meaning that we are governed by the health ministers from our member states. We have 9 member states, and these actually convene once in a year through the Health Ministers Conference. And with this conference, they actually provide overall political and policy guidance to the organization. They address policy matters, review regional health strategies and programs, and define priority activities. So they really are a policy and accountability engine. So through them, formal resolutions under the Health Ministers Conference have urged increased financing for maternal or child health, and mandated regional annual health financing reporting to track the commitments and spending, giving ministers this lever to press for specific budget protection and growth for women and child and adolescent health. The second tool that we have what we call the Best Practices Forum. And this is, again, a convening forum where we bring together proven approaches, which include financing and accountability for children's well-being. From the Best Practices Forum, recommendations then move to what we call the Directors Joint Consultative Committee, which is EXA's highest technical committee in the health community. And the resolutions from the DJCC are then very binding in the sense that they go to the Health Ministers Conference as resolutions. This pathway has already translated a lot of child-focused evidence into adopted ministerial actions. The third tool that I'm going to highlight is that we have health economics and resource allocation support to our member states and beyond. So through the health economists, what we call a community of practice, and a model that EXA has spearheaded called the Tanzi model, a health financing model, we're able to tap into the member states' technical teams so that we're able to support them with allocative efficiency and priority setting to make sure that the women, child, and adolescent health case in budget negotiations is available. So we bring evidence to the countries to support cost-benefit program costing and value for money briefs. So just to make mention on the model, it involves running simulations on a range of policy questions. For instance, you can actually run a model saying, what's the effect of increased spending at community level for ANC coverage, for instance, or would additional community health workers significantly increase immunization coverage rates? So the model then is calibrated in the process and ensuring that the outputs produced do not significantly deviate from the known or expected outcomes. The other tool that we have an adolescent nutrition advocacy strategy, which identifies gaps in accountability tools and guides creation of monitoring frameworks and coalitions that keep adolescent and maternal child investments prominent in national plans and budgets. We've also been working on specific efficiency and fiscal space instruments, especially on food procurement and regional manufacturing in collaboration with other organizations. So we are really supporting the development of guidance and evidence on food bulk procurement. And we all know that when we do local manufacturing or regional manufacturing and food bulk procurement, it means that we're freeing up more money for more money in terms of the domestic funds that can be ring-fenced for other services, including women, child, and adolescent health. We have also embarked on coming up with strategic partnerships that are going to ensure domestic resource mobilization advocacy through new MOUs, and ensuring that in those MOUs, we're including resource mobilization and domestic financing advocacy. The last one I want to make mention is that we are partnering with different organizations to really bring together conversations surrounding this particular reduction on development funds, in the sense that we have done an analysis, a landscape analysis for all the member states in our community, and we want to convene a health and finance leaders to align on domestic resource mobilization. There's no sense in us meeting by ourselves as health sector. And I think this was also mentioned in the minister's speech, the Minister of South Africa, that we need cross-sectoral collaboration. So EXA has done a landscape analysis. We have really try to see the best solutions that can bring about a blueprint that ministries or even the countries as a wider sector can use to make sure that they can free up more domestic financing, ensure that there's proper budgeting, there's proper budget execution and absorption of the funding. Thank you, and over back to you, Dr. Ebere.
My apologies, I was speaking on mute there. So you'd think after all these years, we would have got used to unmuting ourselves. Thank you very much, Dr. Chisenga. Thanks for keeping to time and for describing a variety of approaches that are available at a supranational level, as how we can coordinate and learn and collaborate and across the common problems that we face here. I wanted to ask one specific question of you before you go off, which is what is ready from you've described these regional tools, which are really welcome. And our first speaker described some of the opportunities around information and the gaps that are there. What tool do you think is ready, perhaps, that could be deployed across countries beyond the Eastern Southern Africa community to learn from the experience that you've already had? If you could describe one that you say, if I were to recommend one tool, this would be it, that would be helpful.
Yes, thank you so much for that question. I did mention our modeling tool under health financing. which we call the Tanzi La Once tool, health financing tool. I think that would be the one, because some of the interventions that we're implementing in our various countries have not been backed by evidence in terms of cost efficiency or cost benefit. And with this tool, it cuts across all the program areas. You're able to really fine tune and say, this is evidence-based. This is something that is going to work. For instance, countries would just come up with a policy and say, we're increasing community health workers. Is this really the way to go? But with the tool, it's going to show you whether this is really something that's going to improve your outcomes or your indicators, or it's actually just going to burden you with in terms of the budget. Thank you.
That's wonderful. And can we signpost any interested participants to where they can access this modeling tool? We can connect them to you. Okay.
Yes,
we'll add
please.
that
They can
in the
just
post.
connect us.
Yeah,
Yes,
we'll
thank
add
you.
that in the post-webinar information for how you can get access to this particular modeling tool. Thank you very much for that. And I'd like to move on to our next speaker. We have started from a global perspective to a regional perspective, and now we're going on to a national perspective. Nigeria has been in the news non-stop for the last 6 months around health financing, from sponsoring the resolution at the World Health Assembly in May. They've just concluded a health financing dialogue, which was open to all citizens to participate in. And there's some really concrete actions coming. I'd like to invite Dr. Ebe Orisheweyemi, who is the Secretary of the Ministerial Oversight Committee for the Basic Health Care Provision Fund of the Federal Ministry of Nigeria, of Health and Social Welfare in Nigeria, to talk to us about the experience in Nigeria and the lessons learned on how they're increasing domestic resources for health. Over to you, Dr. Ebe, and thank you for joining us.
Yes, good afternoon, everyone, and thank you, Dr. Ebe, for this opportunity and the partnership network. It's my pleasure really to be part of this and to speak on behalf of Nigeria. So I would just, because we have time is limited, I'll just go to some key points to highlight what we think is our experience. And most of this will draw from the just concluded for the dialogue on health financing. We'll try to reimagine what health financing would be for us as we move particularly in this era where donor communities are withdrawing a bit, so I've highlighted earlier in the dialogue. So principally, interestingly, what we've done does align with sort of what you, Dr. Berry, concluded as the key takeaway from the address by the host, Honorable Minister of Health, in terms of political will, policy coherence, and intersectoral collaboration. So in Nigeria, what has happened, and most of this is drawing from what we all reviewed at the conference, was that first, I think when we talk about domestic resource mobilization, what we need to look at ultimately first, if the pool you're drawing from gets bigger, then what you have for health automatically gets bigger. And Nigeria has really demonstrated this by global macroeconomic reforms that are taking place throughout the country. So this has started from making some hard decisions around how we tax, coming up with some innovative taxation, expanding the tax pool, removal of petroleum subsidies, and also other changes in terms of how tax is generated and collected to streamline that. That has actually led to some significant growth in terms of the GDP 3.6%. We know that's still suboptimal to where we must be in view of our growing population, but I think we do appreciate that growth. And that has reflected in health budgeting, substantial increase in the health budget over the last few years. It has literally doubled in the last 2 years, about 1.07 billion to about 2 trillion to about 2.4 now for the health sector. This is higher. But that in itself does not necessarily always translate in all the conditions we have, like of 15%. It does show significant improvement in availability of resources for health. And since the Abuja Declaration is like an aspiration, we do pull together all the spends at various levels of government. Nigeria operates 3 distinct levels of government: federal, state, and local government. See, we're getting better in that. So with those global macroeconomic reforms, there's more money for health. But then if there's more money
Sorry
for
to
health,
interrupt you, Dr. Weber. Can I ask you to speak closer to your mic because your sound is not as clear? Thank you.
okay, is this better? Is this better?
Yes, it's better. Thank you. Sorry to interrupt.
Okay, then that's fine. So I'll just speak louder because I'm using a headpiece. So linked to that now comes down to what we're doing specifically in terms of improving resource mobilization. So what we've done some years back, which is now being leveraged on for improvement, is we have a law that actually allocates money for health, the Basic Care Provision Fund, which is overseen by the Honorable Coordinating Minister with key actors within the health sector. This fund takes 1% of the federal revenue and allocates it to health, principally primary health care, and it's used as a catalytic fund to drive other things. And those effects we have seen about making the money available to target, to jumpstart community-based insurance schemes across the country, to even actually bring to life the state health insurance agencies across the country. This has been a catalytic effect of having this fund that is backed by law. We've also had and as part of the health sector reforms, because this fund has been there, what we've done is now make the fund the center of the Nigerian Health Sector Renewal Initiative, which is really the vehicle we're using now as to implement our health sector reforms. And the real reform that has taken place there is the alignment of political will from Mr. President and the state governors who signed the compact that this health sector reform initiative, they will invest in it and they will implement it. And to make this happen, we then did what we had to do to allow intersectoral collaboration by implementing what is called the swap approach. So it's a sector-wide approach. So in Nigeria, even though donor resources is dwindling, we now have all donors sitting around one table, pulling their resources, all that they have around the table, identifying what each person is supporting so that we eliminate duplicacies, we eliminate redundancies, we eliminate wastages. And based on this alone, we've been able to raise in the last 2 years an estimated $3.4 billion as a pool of fund that is going to primary healthcare and enabling us to expand both insurance coverage and other input parts of the healthcare that we are doing. So apart from just trying to raise additional resources domestically, and they did mention already that as a response to donor withdrawal funds in Nigeria, the president was able to mobilize through the push from the Honorable Coordinating Minister of Health an additional $200 million or thereabout to sort of cushion the effect of that. But we are seeing the swap approach being the key to actually transiting African countries away from donor resources to more local resources by agreeing on one common plan, one common conversation, and one mechanism to guide health sector priorities and to fund them by everybody bringing what's available to the table. So that way, we don't have programs, 2, 3, 4 programs doing literally the same thing in different ways and losing efficiencies. That also enables things like crowd pooling using group purchase organizations, which we are doing about to take off now in Nigeria with Medipool and other initiatives that when people sit together around one table. So that is really the key lessons. Other things that have really happened is also to improve the efficiency of spend. There's not enough to raise the money. The efficiency of spend needs to be there. Because without that, even with the little you additional funds you raise, you will not be able to actually use that to get the outcomes you want. So as on that, with the swap approach, we now have what we call the annual operational plan, the AOP's development based on the National Health Renewal Investment Initiative. So unlike before, Nigeria with the states and the federal capital will almost be as if we have 37 countries running within one country. But with the AOP, everybody is now domesticating what aspect of the national priority need to do within their states, which is like their regions, to be able to get the health outcomes we want. With that, we're seeing a lot of duplications being removed. We're seeing a lot of cost efficiencies coming into people's plans. We have also seen that because people's plans are now concrete, more transparent, seeing state governments willing to bring in more resources to support those plans. We've also seen a catalytic effect of using this, the Basic Health Provision Fund and swapping investment, particularly in primary healthcare, because the Basic Health Provision Fund had some little resources for primary care revitalization and infrastructure equipment and human resources. And this has stimulated state governors, regional governors, that is, to invest in primary healthcare. We're seeing the incremental resources from that. And I think to begin to round up, important to this, to actually ensure that your domestic resource mobilization actually counts and show credibility, so that even for donors that still remain within the space, that we have the trustworthiness to invest on a common platform for one plan, like we're doing through the Super Push in Nigeria, is accountability. The way we're tackling this is actually by going more digital and having we've now just developed a software that all the facilities can use to make their plans of what they need to spend and to account for what they spend when the money comes from the different levels of government. And also, learnings from this has also informed that we need to pay more for results and inputs. Additional resources we are getting, like from the impact program and some World Bank financing we're recently also getting, they are all going to be pay for hours, so they're paying for results. And what that does is that if you look at it categorically, the payment you're going to get for the results are actually just a fraction of what you're going to need to spend to get that result. But the whole concept of doing that and knowing you'll be rewarded for doing that is also causing state and local governments more recently to mobilize resources and to address the priority health outcomes we have, which is getting functional primary healthcare centers, reducing maternal mortality, addressing nutrition, and also ensuring that we have referrals and also aiding to see that emergency care is available for Nigerians at that level. So in summary, the key things are: one, global economic reforms are important to generate domestic resource mobilization.
Yeah.
Having a backing by law is important to ring-fence funding. Undertaking health sector reforms using a sector-wide approach that comes around one plan, a set of priorities, and bringing everybody's funding to it's important across domestically funded programs and whatever donor programs you have led. And lastly, accountability by proving transparency through use of digital tools and also other places to increase value for money. Thank you very much.
Thank you very much, Dr. Oga, and that was really, really helpful. So we're going to move on to our final speaker, and just to remind our audience that we will take all the questions when all our panelists have spoken. And our next speaker is from Asia Development Bank, and it's Yengpruk Sawan, who is a finance senior universal health specialist in the Asia Development Bank. And I'd like to invite you to, we've talked a lot about domestic resource mobilization, but we also recognize that there needs to be investment to grow the domestic resource from which we will draw for health. So I'd like you to share your reflections on how development and finance and development partners can support this DRM agenda. Thank you and welcome.
Good afternoon. Delegates, and thank you very much, Dr. Ebere. So I'm just going to spend the next couple of minutes just really talk about the role of finance and development partner. So my name is Vasantara from the health sector. So just briefly, that we are a multilateral bank in Manila. So this is where we actually, most of our governments are actually in the regions, but we also do work with various governments across the world. One of the areas I wanted to mention here is that our strategies is working toward universal health coverage in the regions, but there's a synergies in with other main area. And a couple example I will provide here is related to the maternal and child health. With the resource, domestic resource allocation, the way we work is that we work with the government to actually mobilize part of their fund in addition to the ADB loan to work on specific programs. So, for example, one of the modality that we have is to support the universal health coverage to the policy-based loan. So the modality here is that we incentivize the government with the disbursement of our funds after policy actions and programs. So one example here we want to show is for the Philippines, and this is really implementation of reforms for the universal health care. And in doing so, this is not only reforming the financing, but also expand the coverage of quality of primary health care. And these are very important services provide for the maternal care and also the child care services as well. The other example and the other modality that we've been using is a result-based loan. And with this one, it's also have to the government also have to perform in a certain program to be able to meet the disbursement. Example of this, quite a large program that we work in Indonesia. And with this, we work to integrate and standardize the primary health care in the two sets of facilities, in a primary public health center, Puskesmas, but also in Posyandu, which is the integrated services post across Indonesia. So one of the main programs we work with different facilities, including the provision of the ultrasound machines, and these are to monitor the presence of stunting and malnutrition across the country. Importantly, we also expand the training of primary healthcare facilities and also community health workers, and this also to promote the reproductive health services. So these are two of the main programs that ADB has been using to support the government to actually achieve the goals for the development of the healthcare systems. One of the other programs that I would like to just to showcase a little bit also is that not only the nationwide program that we're working with, but in sometimes the government also need a support, especially in the hard-to-reach area. One example that we work with is with the government of Meghalaya, and this is a state in northeastern India. So even though they have a population of 3.3 million, there's actually a third of them are living under the poverty line, and also very high burden of malnutrition among the children. So with this, we actually work with the national, not only national government, but also state government. And it's in this case to support not only the maternal and mental health part, maternal child health, and also the early childhood development aspects of that. But in doing so, do we actually expand the already existing health facilities, primary health care, and also constructed a new one? The way this work is actually provide the foundations for the daycare services for young children, but also to improve the nutrition for mothers and child, and also the upgrading these facilities as well. So across these examples, what we wanted to show is that a multilateral bank like us can actually promote the universal health care and also working in different aspects of women and children and also adolescents health as part of the development program. In doing this, there's various financial instruments, the one that I have presented, but also we can also support as a development partner in terms of technical assistance and also capacity building. In addition, we want to mention that thank you very much for this opportunity, and this platform where we can actually exchange knowledge and lessons and lesson learned with the programship that we have worked in different health program. And so then even though our experience are mainly from Asia, but certainly we appreciate this opportunity to foster the South-to-South collaboration.
Thank you very much. Thank you very much. And it is really important to stress how we can learn from the South Asia region as well as from our own, and that there is learning from across the globe, and we need to tap into all the opportunities to learn and learn from both successes and failures. So thank you. Dr. Yengpru Sawan, and I apologize for I practiced this, but I do apologize. Thank you very much for your tolerance of my poor pronunciation. And so we're now ready to dive straight into some of the questions. I'd like to ask all our panelists and any of our VIPs from the first part of the session who are still online, Dr. Megdes, Dr. Khosla, please get your videos on, and I'm going to start picking some of the questions, and the team are helping me to aggregate some of those. Some of the questions have already been answered online, and thank you all very much for your written answers, but I want to pick up on what seems to be a recurring theme across those, and that is the question of accountability. And we've had the question asked from the perspective of what innovative governance or mechanisms have you seen that are working in the African context to ensure that domestic health financing commitments are not just made in the sort of, now that everybody's flavor of the month, but they're sustained all through the political cycles. And then there's another question from the other perspective, which is how can individuals, organizations, experts, the media, how can they contribute to keeping this accountability focus? How can they engage at domestic, at national and regional and continental level in this dialogue around improving access to resources for health? So I'd like to kick off, since we still have Dr. Megdes online. I would love to ask Dr. Megdes's reflection on that. As the Minister of Health yourself, how do we, the community who elect ministers such as yourself, how do we keep you accountable? Dr. Megdes, are you able to join us? You're on mute. Okay, I will put that question if there's any other of the panelists want to take that question. Dr. Rajat, go ahead.
Thank you for that, Dr. Obere. And just to briefly respond, there are a few rather important initiatives that are ongoing. The first is, of course, the Africa CDC-led initiative in terms of the accountability framework for the Lusaka agenda and the implementation work that Africa CDC is pioneering, and there is a lot of work going on in that regard at the AU level, which is worth noting in this regard. There are a couple of other things I do wanted to emphasize. The second is with regards to the Global Leader Network itself. While not captioned as accountability platform, it is providing unique opportunities for peer learning and peer-to-peer exchanges in terms of how can we accelerate momentum. And we work through a tiered model and an approach whereby we are not only looking at excellencies and heads of state at the highest level, we are working regularly with the ministries of health and with the divisional ministries underneath them. So we do have this tiered network, which helps us build in a momentum on how we can transform these commitments from paper to reality. And then the final piece I wanted to say is that there is also a lot of work that is happening at the sub-regional level and at the country level as well. There are some very strong national accountability mechanisms, and indeed at the community level, social accountability mechanisms that are working remarkably, not just in terms of ensuring accountability, but also providing that feedback loop that is often so important for the governments, for the policymakers, to make sure that these commitments are being implemented into action. And then, as I said, there is at the sub-regional level, we do have a lot of work that is starting to happen and emerge from SADC region, and the work that is happening through the focal points is providing us with an ongoing dialogue with the ministries of health on specific issues, particularly in relation to sexual reproductive health, but also women and children's health more broadly. I hope that was useful. There is a lot to unpack there, but happy to come back if time allows. Back to you.
Definitely. Thank you very much. I think that's a really opening question. And I actually want to engage in the media representative who asked about the function of the media. And my personal view is that the media is the fourth arm of government. It is the accountability mechanism that through which the electorate hold the politicians to account. So we're encouraging and advocating for more media engagement in the conversation about health financing, about efficiencies and value for money in the health sector. We need our media to engage in understanding the narrative. We're very pleased that you're here today. We need you to understand the problem, understand the opportunities for intervention, and help us as citizens to hold our elected leaders to account. So it's a really important part of that. Now, there's also a question specifically about how do we actively engage the private sector in this agenda around domestic resource mobilization. In many countries, the private sector are not just the biggest providers of health, but they're also the biggest part of the economy. They're the largest employers, and therefore they gain from having a healthy workforce. So how do any of our panelists want to talk about, and Dr. Ogo, I was going to ask you to reflect on that. How do you engage the private sector in this dialogue around resource mobilization?
Yes, thank you very much for that. I think that's like the last frontier in terms of the challenges for resource mobilizations across health, particularly in Africa. And it's constrained really because even though there's a very vibrant private sector, they still we don't have this large conglomerates like you say, like the Pfizers and all of that, where you have this very big company that has this huge amount of resources that can commit significantly. So what we've done first is trying to help them get organized. So in Nigeria, we have what we call the Private Sector Health Alliance for Health, where they try to serve as an anchor for private sector sources for specific areas of intervention in health. And that has been working quite reasonably, but I think there's room to scale up. The second part is really helping them to contribute more into the economy of health in such that less of domestic resources goes overseas, both in terms of travel for treatment or for procurement of commodities and modern equipment. And so there's more resources at home to do that. And we have the presidential initiative of improving value chain for health in Nigeria, PVAC, and they've been able to really mobilize a lot of resources and make that available at literally low interest rates to the private sector to stimulate them to come to upgrade local production of medicines and commodities, and also just participating in the whole health sector as active players. In that way, indirectly saving us foreign exchange and indirectly improving domestic resources for health. So that's really big approaches we've been using. And then the last part is really encouraging them and bringing them more and more into the table to hear what they are doing in their spheres and seeing how we can help them. So we had a lot of speakers of the private sector and just concluded a dialogue, and they were very excited about the giving them seats at the table to have this conversation. But that's the two key approaches. One, you need to get a private sector-led coalition help that private sector can trust and mobilize around to input resources and make their inputs to where they would like to invest. Two, you need to set up a mechanism that is supported at the very highest level of government to actually drill down and see where can we make cost savings and save forex by actually improving our value chain for health locally as a source of indirectly improving resource mobilization for health. Thank you.
Thank you very much, Dr. Obe. And Dr. Rajat, did you want to follow up on that? Your hand is up.
I did.
Yes.
Thank you. And actually, if I can have 30 seconds to also go back to your media question as well. I do think, in addition to what you rightly pointed out, there is a critical role that media can play, especially in the context that we are living in, is with regards to combating mis and disinformation. At this point in time, where social media platforms are ripe and probably the primary source of information for a lot of people, it is critical that media outlets do responsible reporting, evidence-based reporting, critically from reliable sources. On the point of private sector, Dr. Obege has already outlined some of the things. I just want to make 2 points, and this kind of connects back, Dr. Ribere, to your previous point to me about accountability. Private sector does have a role to play, but we do need to make sure that it is not seen as instead of the role and the responsibility of states themselves, who have the primary responsibility to provide resources in this regard. Therefore, what is important is that when we do look at the private sector, we are clear in terms of the engagement of private sector on what issues and their contribution. We are working very closely with a cluster of partners in terms of looking at models of partnership, and particularly public-private philanthropic partnership models that can address the resource needs of the countries that we are meant to serve. So just wanted to outline that it's important to connect those two pieces in the conversation.
Wonderful. Thank you very much. And that's a really very important point. Dr. Tina, did you want to come in here?
Actually, thank you so much. I actually wanted to add to the media question in terms of accountability. I think they're a very major player in ensuring accountability. They can actually help with following policy all the way from formulation to implementation or lack of, and bring our leaders to account in terms of coming up with docuseries that are very investigative to the point of where they can actually now bring out that accountability to the rest of the leaders and all the policymakers on what they're doing or what they're not doing. Thank you.
Absolutely. Absolutely. Thank you very much. And on that point, I want to call in Dr. Ogochukwu. We talked about the challenges of limited data to actually monitor what we're doing in the health sector. And there's even the hidden minorities within we already identified that women, children, and adolescents are already the most marginalized in our populations when resources are scarce. But within that, we also acknowledge there's even further marginalization of mental health problems. The focus tends to be more on physical diseases and needs than mental health. How can the tools that the WHO has, the information management tools that WHO has developed, enable us and support us to actually identify the needs in these even more minoritized populations, those with rarer, the more challenging to identify mental health problems? Over to you.
Thank you so much, Dr. Ebere. Firstly, I mean, the tool that I spoke about, which is, the health accounts for expenditure tracking, is the framework by itself actually is very adaptable and countries can use it. And I think, as I was mentioning at the end, part of the issue would be to what extent are the needs of these people and how the funding flows are really documented and tracked. If I take a step back to, the issues of the accountability points that have been raised. When we find that spending is shown publicly, for instance, governments are able to publish and say, this is how much you spent on A, B, C, D, E, and so on, then people can interrogate, not just the media, but the public can actually see this is what is happening with the funds that are coming from us or with the public resources based on our tax revenue and so on and so forth. So for even the rarer conditions, for instance, when people have mental health issues, a big the challenge there would be, how are these documented at the points where they are seen, so that funding that has been spent to deliver those services can be tagged back to when we're estimating then the spending on all of this, and that remains a challenge. But beyond the tracking of health financing, one of the things that helps to track that better are the other information systems that exist in countries. For countries that have health insurance mechanisms, for instance, the more they're able to digitalize and use electronic platforms for monitoring provision of care, for tracking claims and reimbursements, then it's a lot easier to tease out how this is going at the population level, rather than having the very broad demographics. And for even those who are not using, they simply strengthening the health management information systems, or for those who are moving increasingly to electronic health record systems, these help us to then really be even more granular in being able to estimate what is being spent. And so I think those are the approaches I would say would really help best. Over.
Thank you very much. And I want to put one final question to our Asia Development Bank colleague, Vasuntara. Tara? Yes, I got that right, Vasuntara. I actually, the question I'm putting to you is from the example of the sector-wide approach from Nigeria. And I'm putting it to you before because I'm a bit long in the tooth. I've been around a lot. I remember a long time. And I recall the first time sector-wide approaches were presented as the way to sort of have improve efficiencies in health spend. And they didn't succeed because donors and funders were concerned about being able to provide accountability about their own contribution to the resource. As a development bank, who also, you have part of your role, you do pool resources, you bring investors' portfolios together. How can we ensure that it works this time? How can we change that so that the one plan, one budget really works? So that is one key aspect to efficiency. I'd like to hear your reflection on that.
Yeah. Thank you very much. And that in itself is actually quite a challenge for the bank. And one thing we have to say is because each of the country actually operate differently. So we work particularly with the government. So each of them actually have a different ways of doing things. But having said that, as a sector-wide approach, certainly, especially now that there are three parallel work that going on, like for example, there's a challenge of this maternal child health and also the communicable disease, non-communicable diseases, and climate related challenge. And each of these partners actually have a very different way of operating. So just linking to one example before, we do work with private sector, for example, but the way in which we pull the funds or we join the fund, we have to actually tailor into how each of the setting work. So it's the same as a public-private partnership. So having said that, we have made some progress, Finland, but I don't think that we actually fully success altogether, because the challenge has already been quite different as well. One example I want to point out is during the COVID-19, we were able to pull that all the partners all together in a short period of time, but that's a very specific challenge. So I wouldn't want to generalize with everything, even for the Asia Pacific experience, but certainly I think there's a room to go, and some of this information like this help us to actually work to address some of the already kind of common health issues, but also emerging health issues as when coming forward. Thank you.
Thank you very much. Thank you very much. And I'm afraid we could go on for another hour, but we won't. I won't keep you. It is a Friday afternoon. I recognize that. I'd like to invite Dr. Rajat to bring us this session to a close, and then we will let you know about the next one. This is the first in the series. Subsequent series will be shorter. We won't need to have the VIP session. We'll dive straight into solutions and sharing best practice. So Dr. Kosal, if I could invite you to bring us to a close. Have we lost him? Have we got is Dr. Kosal still online?
Checking to see. Give me 1 minute.
Right. If we've lost him, and I won't want to keep us all too long, I'd like to start by thanking, first of all of you who are online. At the top, we hit, I think, a maximum of 183. We're now down to still keeping on over 120. Thank you all for joining us. Thank you to all our speakers, to our ministers, our VIP guests, for their reflections, their shared solutions. And I really want to thank them for the solution focus that we've taken throughout this session. We're not just talking about problems. We know what the problems are. We also know that this is not a transitional problem. This is the new world in terms of financing. And it's very gratifying to know that we've actually taken the lead in developing and implementing those solutions. I'd like to thank the panelists who have all discussed case studies, specific interventions that their organizations, their countries are investing in. And today we've heard that political leadership combined with the right technical tools can sustain and expand financing for health in general, and specifically financing for health needs of women, children, and adolescents. We've heard we've highlighted specific levers from fiscal policy in Malawi, evidence-based reforms in Ethiopia, and regional and global partnerships from Africa CDC, WHO, the Asian Development Bank. The cross-cutting message here is coordination and collaboration, and how we must align all these initiatives that the GLN mapped out, that Dr. Kosal presented at the beginning of this, to ensure that we avoid fragmentation and optimize impact. This is the episode 1 in a series. Our next webinar will be on the 3rd of October. It will be 90 minutes long. And we hope that you will all contribute to the survey that will be circulated after this. Let us know what we can do better, what we should do differently, and how you found this session. And I'd like to thank the interpreters online, all the colleagues behind the scenes who have kept the technology working and kept us on time. And I would like to thank first and foremost, and finally, our host minister, or Minister of Health for South Africa, and President Ramaphosa as the leader of the Global Leaders Network. Thank you for your commitment. And on their behalf, I'd like to thank you all for joining us today. And hopefully see you all on the 3rd of October. It's been my pleasure, Ebere Kereke, to moderate this session today. Thank you very much. Have a good weekend. Bye-bye.